We're delighted to continue that momentum today. It's a real pleasure to chair this session, which features two outstanding leaders from the Association for Simulated Practice in Healthcare, aka ASPE, a key organization at the forefront of simulation-based education and patient safety in the UK. We're honored to welcome Professor Sharon Marie Weldon, President-elect of ASPE and Professor of Healthcare Simulation and Workforce Development, and Colette Laws-Chapman, President of ASPE and lead nurse for non-medical and patient safety simulation, both of whom bring a wealth of expertise and experience in advancing simulation within healthcare system. Each speaker will share perspectives from their work and leadership within ASPE, highlighting the evolving role of simulation in healthcare improvement, education, and system transformation. We'll begin with their individual presentations, approximately 20 minutes each, followed by a chance for open discussion, questions, and shared reflections. The floor is yours, Professor Weldon, to start your presentation. If you want to share your screen, please.
Thank you very much, Mariam. I'll share that now. One moment. Stay with me.
Sure, take your time.
Still there. Okay. Can you all see that?
Yes.
Fantastic. Thank you.
Perfectly. Yeah.
Okay, fantastic. So thank you for having us. So we're very excited to talk to you about this concept of transformative simulation. And some of you may be wondering, what do we mean by transformative simulation? And also, why do we need another term? Just bear with me. There's something right in the middle of my screen. There we go. So what we want to do today really is give you an overview of what transformative simulation is, the what, the why, and the aspirations we have for it, particularly with ASPE and beyond. Talk about how we need to think about developing the processes with it, with design and brief. And then Colette has got a wealth of experience in using transformative simulation in practice. And so she's going to put that, show you how that works within her healthcare organisation within the UK. And then we'll have a little bit of time for any questions or anything. And it'll be really useful, I think, for us as well to get your perspective in Morocco about whether you're doing this work already, which we probably suspect you are, and maybe just haven't framed it in this way, or if you're not, do you think it would be useful, or are you doing something different? So we're looking forward to hearing about that. So let's move on. So really what we want everyone to get from it is hopefully by the end of this webinar, you'll be able to describe the concept of transformative simulation. You'll understand the 7 clinical simulation-based I's, which we'll talk you through and how they can be applied. And we can have a bit more of a critique about the further knowledge that's required to advance this area of simulation. So really, it's quite, I guess it's a principles-driven framework, and that it's quite different to how we use simulation generally for more instructional, educational purposes, and that it's more about bringing people together, people with different perspectives, different knowledge, different skills, and kind of respecting that value of what everyone brings, that reciprocity, the relational elements to make change, to transform how we do healthcare. So it's not necessarily bringing novices or people who don't know anything together to tell them how to do it. It's the opposite. It's bringing very knowledgeable people together, but with different types of knowledge and experience to get them to enable them and unpick how we can do things differently. And really, if you think about simulation's purpose, historically, when we've been talking about simulation, and particularly in the literature, we often go back to Gaber's 2004 definition, which was it's a really good guiding definition. But if you look at it, it talks about simulation as a technique, not a technology. And it talks about, it's used to amplify experiences, but it's talking about simulation as the act. It doesn't tell you what simulation does. It just tells you that it's a technique and it's not a technology, and that it amplifies those real world experiences. But why? What's our reason? Why would we use it? And then as time's gone on, we've kind of, there's been certain terms that have popped up, and one of the probably most predominant is simulation-based education. A lot of us know that it's the one that's used most regularly, and it kind of says what it does on the tin. It's simulation-based education. We use it to educate. So that's the purpose there. But as time's gone on, but there have been other purposes, and I'm sure you've all used simulation very creatively. And if we go to the Healthcare Simulation Dictionary, they started to talk about simulation having 4 main purposes, and that being education, assessment, and health system integration, facilitating patient safety. So you can see then we're starting to broaden the education. Someone got their mic on? Someone's left their mic on. Brilliant, thank you. So yeah, you can see from this definition in 2020, we are starting to broaden our understanding of what it's doing, but we still haven't really got to grips with the breadth and depth of what it can do. And this is where we came up with this term, transformative simulation, as a tool to transform health and care through collective understanding, insight, and learning. So learning still occurs, but it's actually, as I said, it's different. It's not about that more instructional approach to education. It's more about understanding insights, coming together collectively and learning how we can make change collectively. And why is this important? You're probably thinking, why do we need to have this definition of purpose? And it's important for many, many reasons. And one of the first ones is the process. If we're doing simulation for a different purpose, it affects the who, the what, the where, the when, the why, the how. So when we're educating, it's a bit more straightforward sometimes in the sense that, we get our learners, we know the group that we're focusing the education on. We usually know the kind of simulation, whether it's skills or some kind of communication, teamwork, and it all starts falling together quite easily in that area. But when it's for more transformative forms of simulation, that's where we tend to have to be a bit more creative, and it can be vastly different depending on the areas you're looking at. It affects a theory we use. So with simulation-based education, we often use learning theories to help us guide in what we do. But when you're using it for transformative purposes, you might be using human factors, you might be using translational simulation frameworks, you might be using engagement science. It depends on how you're using it, but those theories will inform the key things that you need to do to design the simulation. And that leaves us on to the objectives and design considerations. When you're doing it for education, you have specific learning outcomes that you want to achieve. But with transformative forms of simulation, sometimes you don't know what's going to emerge, and most often you don't. So it's more objectives of what you're trying to do. Are you trying to identify latent safety threats in a system? Is your objective to improve something that's already done? So it's not about learning outcomes anymore. It's about the objectives, and that affects the design considerations. And it starts affecting all sorts of things then, your purpose, your notions of some of our key concepts around fidelity and authenticity. Are they so important if you don't have a specific learning outcome, if it's more about engaging people? And it's also about the potential and opportunities. We need to understand our purpose, because if we understand it and others understand it, then it opens up new opportunities of how it can be used, and others understand the tool and what's available. But if everyone always sees it as just a tool for education, they don't see what we can do beyond that. And it's about legitimacy. So what we've seen in the UK particularly, but all around the world, and that's what I'll be interested to hear from yourselves, is that it's often most simulation comes and is resourced under education budgets, because most people, especially beyond our simulation community, see it as an educational tool. And so it's not really legitimized to be used for other things yet. It's starting to grow in certain areas, but it doesn't seem to have that legitimacy as a tool for anything beyond the education approach. It also affects how we report it in journals, how it's debriefed. We'll talk a bit more about debriefing in a minute, but there's an introspective versus extrospective approach. And then the thing that's really what drove me with a lot of this work is it really affects how it's researched. That makes a huge difference. And so we really have to have that clarity to move forward. And also it's, what it can potentially be and what it can potentially do and its potentiality. So there's a lot of reasons why we need to be clear on our purposes in simulation. And so what we did to try and, when we started thinking about this new purpose and how it was, quite creative and it was being used differently everywhere we could see. But the problem with it is there was no consistency. So everyone was calling it something different. Everyone was doing something slightly different. And so you couldn't bring it together to understand it. But ultimately, it did all have a goal and a single purpose, which was this transformation. But we wanted to understand more, and we wanted to search the literature to see what was out there, which is not easy when you have so many different terms and you don't know what terms people are using to describe it. And so the way we did it is we'd started collecting papers that we believed fitted the transformative simulation purpose definition. And when we had some of those papers, we used a process called pearl growing and citation searching and can't see this one, snowballing. So it's basically where you look at these papers, you see what citations they've used, you also look who's cited them, and it's a cycle that just keeps going round and round until you've found as much as you possibly can. And we also engaged with the ASPE simulation community. We did Twitter Fest, we did webinars, we did all sorts of activities to try and understand more who was doing this, where, and what they're calling it. And through that process, we were able to identify a series of papers. In total, I think we had 87 we identified around the world. And you can see what we noticed when we looked at the papers is this trend was increasing from the papers we found. And it only has a sharp dive here because we stopped the review in January 2023. We created a taxonomy because taxonomies are really important when you have an emerging field, because what you want to do is bring everyone's knowledge together, the stuff people are already doing, and try to put it in a framework that we can all agree moving forward so that we all are talking from the same hymn sheet, basically. And that's really important. And this is what we did. So we used everyone's work that we were able to find, and we thought about what are the objectives it's trying to achieve. And we originally started with 5, and we ended up from this process with 7. And we called them the 7 simulation-based I's. So sometimes, and they're all based on the objectives. So they're all quite creative and different. But these I's were the key objectives that people were using the simulation for. And we felt it was important to distinguish these because, as I said, it does affect the theories used, the design, and all the different processes. So you can see here, we'll talk through them. And we created this lovely rainbow. And I'll just give you a quick bit of background on the rainbow, but it's because a lot of this work was happening during COVID. And in the UK, we used the rainbow particularly to support our National Health Service. And it just felt very timely. It's very inclusive. It was very much about, what was happening globally with the pandemic. And because we had these 7 simulation-based art, just felt right at the time. And so it's a nice legacy to have from a very difficult period. But ultimately, what we found in each category was with the innovation eye, it was about using simulation to introduce something new into a clinical area. So how are we going to introduce something new? Is it a new piece of medical equipment? How is this going to work? Something along those lines. They were the kind of papers we were finding. With improvement, a lot of you might be familiar with this, but it was how simulation was being used for like quality improvement initiatives. And then we had intervention, when the simulation was being used for a specific intervention to try something new, to see if intervening in a certain way would make an effect. But then when it started to change, as we were seeing also simulation being used to involve people. So it was about involving stakeholders and people who are not normally involved in simulation, like maybe patients or carers or people from IT or managers, and actually enabling them to help us transform healthcare and give us their views on, what needs to be changed. Identification was one of the most popular ones, and that's things like I said before of identifying latent safety threats, using the simulation to understand what might go wrong if there's, a certain emergency, that kind of thing. That was quite common, and we're definitely seeing more and more of that. It's a very good use. The inclusion was about including key people within the system already. So not just focusing on the clinicians who are doing certain clinical work, but ensuring you're including those key people along the way to make those informed decisions. And then the influence, which was another very interesting one. People were using influence to either change culture, to show why something wouldn't work if there was a management change, for example, or a policy change, and they felt it wouldn't work. They wanted to prove it through the simulation. So it was really interesting. And although these were the 7 we found from the literature, the work we've done since with the simulation community and globally and in the UK, we know that this is probably going to evolve, and there'll probably be more because simulation's being used more and more creatively. And we're starting to see more case studies and examples of how that's being done. But it gave us a taxonomy and a framework to start with. So what we know now from that work and work we've been doing since is that transformative forms of simulation are happening globally. Simulation is being used to transform health and care, not to educate people within it, but to make actual changes. There's great frameworks and examples of how to do it, and they align with the SBIs, but we need a bit more work on understanding that more fully, and we're doing some of the work on that currently. There is still a lot of confusion because people haven't fully adopted this idea of purpose in design concepts and potential applications. And what I see a lot in the literature, which I find quite difficult, is that, and it's hard to know if this comes from people confused when they're writing things up or if it's the reviewers from the journals. But often someone's doing a transformative simulation of some sort, but they're trying to write it in the way you would a simulation-based education approach, and it ends up very confused. The outcomes aren't matching what they did, and it's so I think that's where we definitely need the clarity. And as I said, it's very difficult to search this stuff if you want to find it in the literature or anywhere. If we don't have a common terminology, it's hard to find it all. So without this clarity and alignment, we won't have collectively advancement in it, and we won't get ultimately the legitimacy of this work, but also, the resources and everything we need, and that kind of collaborative working together to advance our thinking. So basically, why is it important? Well, if we make it legitimate and people understand that it can be used in this way for this purpose, it's more likely to unlock resources for all of us because people will see its value in a different way to what they're currently seeing it. It also enables us to do research, which generates bigger impact for us to show the potential of what it can achieve and how valuable it is. And I think it's just about its evolution. It's about us coming together under common terminology to really be able to drive something forward and just work this in a way that allows us to explore it further and let it evolve. So I'm going to skip through some of this because of time and there's a lot more to go into, but I'd happily pick this up at some other point with people if you want to. And we have a specialist interest group for transformative simulation that we'd love for people to join. We want everyone to come together and help us take this forward. But really some of the big things we've been looking at recently are about design and debrief. And some of the work we've done, and this is on the ASPE website under our resource page for transformative simulation, but is to look at what are the key difference with a simulation-based education approach versus a transformative simulation. And we've tried to pick out some of this work, and Colette and myself are writing a paper about this currently. But just so people start to understand different things you need to consider for these different purposes. And it really kind of does lead itself into instructional theory or instructional design. And, with an education approach, you're more thinking about the learning objectives, as we said before, about providing learner guidance, eliciting performance, and providing feedback and assessing performance. But with transformative simulation, it's more about those objectives. It's a recall of your prior experience, not a new experience. And it's about participation guidance, not teaching, and eliciting information from, the richness of what everyone brings into that event. So these are the real key areas of it. And, when we think about the 7 based I's, and this is something one of our colleagues put together, which I think is quite lovely. It's about this innovation. How do we create something new, novel, or improvement? We know this can be done better. Let's try things out. And it works. If you work your way through the I's, one thing that we did notice is that most simulations, transformative simulations, they don't focus on one SBI. They might do sometimes if it's an identification one or an improvement project, but often they will have several I's as objectives, but there'll be a primary, secondary, and tertiary, for example. But I think where we need to get to, particularly in an advancement perspective, is to be more intentional in how we are designing and thinking in these frameworks so that we really get the most out of the transformative simulations. Whereas currently, I think people are doing it and doing some great work, but it's very much based on kind of intuitiveness and experience. And I don't think that's where we're getting the most from it. And the debriefing is very different for transformative simulation. It's some work we're currently doing as well with ASPE and different people. And we have a workshop for our ASPE Experience Day, which is just before the conference, which is going to be really exciting, bringing together some of our specialist interest groups. So this one, we're bringing together our transformative simulation, our debriefing simulation in special interest group, and also our research special interest group to look at understanding the debriefing models we already have and actually what we need for transformative simulation. because normal debriefing requires us to consider our own learning, to have that feedback, and to have that kind of introspective growth in our development. But with transformative forms of simulation, it's actually about the extrospective. It's about what do we give back from what we've understood has happened so that we can transform and make changes. And so that's different. And the different SBIs have very different needs there as well. So it's another piece of work that we're doing. So I won't go through all of this now. What I will do is hand over to Colette, who's going to very eloquently put it into practice for you and hopefully bring it to life, whereas I've just done the research side. So I'll hand you over.
No such thing as just, Sharon. It's been helpful, so helpful for you to share that. Are you happy to just move my slides on and rather than us swap and waste time? So hello everyone, I'm Colette Laws-Chapman, just going to try and talk to you about putting it into practice. So yeah, next slide, Sharon's great. So I currently work within a large teaching hospital in London as part of our National Health Service, but it's a predominantly acute secondary care, but we also have community services built within our organisation. And we're trying to focus on the aspect of improving outcomes. So we've been spending many years obviously trying to educate, many years trying to use audit to improve patient outcomes, but our focus is shifting heavily to use the different modalities of simulation. And I'm very fortunate that we've got an innovative approach with an interprofessional trust-wide. So we have 23,000 staff in our organisation. So we have a college of healthcare and there are multiple groups. One of them is simulation. And so we have an interprofessional group that helps us think about not just education, but using simulation as Sharon's articulated. And we're trying to really move away in healthcare here in the UK from reactionary, bureaucratic, blame culture to a much more open, fair and just culture. So thinking about all the work from Eric Holnagel and safety 2 concepts as well as having a systems focus from human factors. So this is kind of what I do every day, which is I really enjoy my job. Next slide, please, Sharon. So what we're trying to do is say that transformative simulation is whenever we think it's appropriate. We're thinking about patient safety and actually staff safety should be within that. Thinking about human factor skills and thinking about the environment, so human factor systems, and then not just clinical. This could be for an educational team, this could be for your security or portering team, this could be for housekeeping or the executive board of the organisation. So it's really thinking about how do we get this right and help people explore the systems that we're working in, either as work as done, work as imagined, or work as disclosed. So the next slide talks about essential components, and these are the fundamentals. And I have found it hard, I have to admit, within a large organisation. When you have buy-in from a small team, you can get traction, but to try and get a whole system to adopt simulation, and as Sharon was articulating so much, everyone thinks of simulation for education predominantly, which is interesting because we certainly didn't start out like that 15 odd years ago, 20 years ago in the UK, but it's important. Inclusion, and that includes everybody. As we know, the psychological safety within any simulation applies, but we want to have change, we want to have ownership, then we need to co-create the simulation and co-create the change. And think about the work as imagined, work as prescribed, work as disclosed, all those proxies of work by Stephen Shorrock. And for me, it's very much my background in nursing is always thinking about health and safety. So it's not just psychological safety, the physical safety of running the simulation for the participants, the physical safety for faculty, but also the department and having a very safe process. And obviously thinking about how we have a learning culture and how we empower our team and include our patients, our service users, our students within that, and try and make it a continuous learning approach. So that's what we've adopted. But the next slide goes much more into assessing the risk. And this is something that I certainly brought in to our organisation after having actually been at a fellow SSH's conference many years ago, but expanding on it now to bring in what are the hazards linked to this scenario, whether that's sharps injuries, which we always think about, but what are the other hazards that can take place? Are we delaying care if we run this in situ simulation? Who might be harmed and how? And so we try and think through every route. So a lot of planning goes into this, and what can we do to control and mitigate for any risk? And then when we're actually running it on the day, what other controls can we do to take place so that the simulation activity still takes place, but how do we also override it if this situation becomes unsafe? Because there could be any kind of error that takes place within the department, or there could be you know, a major incident, or all sorts of things can happen where we had someone not part of the simulation, someone slipped over last week on a wet floor, and that meant the simulation had to stop because it sort of took out a whole part of the emergency department while things were being sorted out. So how we assess risk in clinical practice is how we should assess risk for simulation. And then, of course, briefing everyone. So we all know about psychological safety, and we've all probably read the Rudolph paper on the safe container, but it's so important to have the lid on the environment that you're working within and contain people. So that takes all that organisation. And this takes up probably 50% of my time. The simulation is probably 10% of my time, and 40% is evaluation and trying to think about doing more of the simulation. But all those really important things that we do with educational sim about fiction contract and familiarisation is so important, even if we're doing this in people's clinical environment. So let me jump to a couple of examples. So using the 7I principles, I've got a few examples here. So identification, thinking about when we've had a redesign of an area. So just 18 months ago, we were redesigning one of our high dependency units for adult care, and they had a lot of money invested in it. And we were asked to come in and help with just thinking about where does the old kit, oh, it keeps jumping, doesn't it? I don't know why. Don't worry. Sorry, everyone. Where does the old kit that they were still going to use fit with the new? So you can imagine we've got these sort of 2010 trolleys, so 15, 20 years old, going in a really high spec area. And that's what we thought was going to be the challenge. And indeed it was. So a critical care situation is where you put something called the stack on the end of the bed, which carries all the oxygen, the suction, and you can move your patient safely, and you've got everything you need and all your monitors. So this old bit of kit, it was still very functional, but it didn't fit in the way they designed the new unit. It didn't have the space for turning the beds with this extra sort of 1.5 foot length on it. So that was going to be a problem, and luckily we did that before the unit opened. And then they had this really great design of the toilet doors opened both ways, which I've never worked in, having been in healthcare for 35 years, which was great. It means if a patient falls against the door and you usually have to try and push it open, you could pull it. But actually, there was no key to unlock the door. And we were going live with patients. This was on the Friday with patients coming in on the Monday. So a little challenging. We need to be brought in much earlier. And it's not a claim to fame, but my most frustrating thing, but also I was really pleased to discover it, was this. Someone had spent a lot of money redesigning this incredible high dependency space. But we found 2 call bells, a red one and a blue one. Well, in the UK especially, it's universally a red call bell, but someone had decided that it was really quite nice that we'd have a blue bell, which meant it was a cardiac issue, and if you pulled a red buzzer, with a different sound, then you must run for that. So it meant you know increasing everyone's cognitive load. Is it a cardiac call bell, or is it a respiratory or other emergency? And of course, the nurses also didn't know which one to pull, so we were causing problems and delays. And interestingly, the alarms hadn't even been linked up. So that's the kind of stuff we can identify before we go live. Next slide, Sharon, please. And then one of the really nice things is before it gets designed, before you waste all that money, we can do it with involvement, but with people. And this was us using tabletop and Lego people to try and redesign the flow through a new radiology department. And we included everybody within that, from the housekeeping staff and the porters to the volunteers that worked in that department, as well as patient and parents. And it was so important. And then we had a mock-up of a theatre suite being designed where they hadn't actually thought about the staff that were going to work in there. And it looked really fabulous, the mock-up, but when we actually did some sim testing with them, they identified that they'd built it and modified it, and Sharon will have something to say about this, I'm sure, but on a male who was around 6 foot tall. And most of the scrub nurses, and I'm 5'3", but a lot of the scrub nurses on that particular day were shorter than me and had to have a stool to reach to go and scrub, which of course was a complication. And then actually the theatre extraction unit was so high that only the surgeons could reach it. So that wasn't helpful when you had a panel in there. So lots and lots of issues. I think I've probably got one more or two more examples there. Oh yes, so this is a really nice example actually, where this is a new day surgery unit where they'd had the parents and the children designing the department. But I don't know if you can see on the back wall where the number 10 is, the images, we were in this sort of outer space area of the day surgery unit. The images that were chosen by the children are behind them, so the children can't see them. So a very simple thing where the children have said, this is what we want, but of course they can't see them because they're facing forwards, and the parents aren't really interested in that. So it's just making sure you have engagement from everybody. And interestingly, this beautiful environment, this is literally about to go live date, and we were helping them test and orientate the staff, and we identified that the doors all opened into one another. So a drug door was open, it would stop the door to the side room. So it's very dangerous actually, and we've spent millions redesigning all these environments. So it just shows you how simulation can save money, and economic modelling is one of our passions to try and identify. Thanks, Sharon. I think I might have one more. Oh yes. And then this one actually was quite a few years ago, and then monkeypox has obviously become a more recent issue, but we tested our hospital. There's a high consequence infectious disease hospital, and so we wanted to test the route from our ambulance ramp outside our emergency department, patient needing to go to CT scan and ITU. And this whole event took 7 hours, and we had it sort of happening in stages. And we had intermittent huddles to help capture the learning from each stage. It was fascinating, but because it was happening in real time in a real place, I say real time, but obviously the debrief slowed us down. We actually used 360 cameras, which allowed managers and people who wanted to see from their own professional or team, like the housekeeping team, they were able to watch that back at a different time. And then we've done that with many others, and what's worked really well is bringing in different technology. So we used a Miro board where they could live comment on the digital feed. So those are some of the examples of where we've utilized transformative simulation to really help. And I think I've got a few more, but I'm happy to stop talking there really, and just say, yeah, there's many more. But one of the things that is so important is reporting this and trying to capture it into something meaningful. And what I'm hoping to do with some work with Sharon is not only focus on the debriefing, but to think about how we also data capture and report so that it lands in a language that the staff can understand it and own improvement plans, but also it speaks to the board, it speaks to the safety specialists, and that's where we're at really. That's where I was going to end it, Sharon. Sorry, I should have hidden a couple more slides. Oh, yes, that was a painful one, that one. And of course, they're all based on our ASPE standards, the work that we do, which we share with you there.
Which, yes, Morocco is adopted now, and we will work together on those going in the future, which is fabulous, very exciting. So I think, yeah, just to finish off and conclude, really, you know, what we're trying to do with all of this work is just to give us as simulationists who are utilizing it in this way a kind of framework and a way to go forward to advance it, understand it, and get that legitimacy and resourcing that we need, as well as the tools that we need to really do it well. So it's a big piece of work that everyone we're working with from all over the world, in the UK, but also we want to extend it to yourselves. Please do join our specialist interest group, come and be part of it. And we want to know now, are you doing this work? What's happening in Morocco? So yeah, thank you. We really appreciate it. And we'll just say as well, if any of you feel like coming across to the UK, we will definitely have Mohammed, which we're very excited about, joining us. Hopefully we'll see some of you. We're going to be in Bournemouth, which is on the coast, in the 11th to the 13th of November this year.
Thanks, Sharon. I forgot about that.
And I think that's it, isn't it?
Okay, thank you, Sharon and Colette, for your incredible presentation. That was very inspiring. While waiting for the audience's questions, I would like to share some reflections of my own on. I was really keen to learn more about transformative simulation because as a word or as a term, it didn't talk to me at first, and I was wondering what's this transformative simulation is about. And surprisingly, I was telling myself, oh, this is something we do all the time, you know, but we found a name to what we practice every day. I'm very interested in teaching soft skills to the trainees and trainers, especially leadership concepts, for example. And while holding workshops and masterclasses with medical educators and nurse educators, we use scenarios, like simulated scenarios about real problems that have happened in wards, like medical errors, relational problems, conflicts inside some teams are based on real stories, and then we reuse them in real scenarios that we expose to the participants who are actually not learners but continuing learners because they're already professionals. And we have this brainstorm about what should have been done differently. So this is what we do on a daily basis. So now I'm really glad to learn that it could have a specific name, which is transformative simulation, something we use based on the simulation concepts. Because if we look at the simulation-based 7 I's that you exposed, Sharon, or the components of this transformative simulation as nicely explained by Colette, I find inclusion, inspiration, influencing, empowering, which is all also part of medical leadership and how to be effective and work effectively in a medical team. So thank you for giving me a real framework of, putting simulation and leadership together. We come up with this term of transformative simulation. Now, my question is that based on your own experience, both of you, what are the barriers to implementing this transformative simulation within current teams?
So I can talk from like a research perspective and what I'm seeing, and Colette's probably better for, the actual practical elements of it in that sense. But from my perspective, I think what I'm seeing is that because it's not recognized externally as a legitimate use of simulation, it doesn't get the resources, it doesn't get seen as like a proper use of, or, you know, something, people don't see it as a proper thing to do. So everything they'll ask of us is to simulate for education. So what we, particularly in the UK, but I've heard about many cases around the world, is that it seems to be, and it sounds maybe like you're in this bracket as well, people who work in simulation, particularly for education, get asked to do something educational, but realize that's probably not what's needed. It's not to educate the team. As you said, they're already very intelligent, experienced professionals. So you end up adapting the simulation and doing it differently. Um, and that's fine, it works to a point, but the problem is it isn't being resourced appropriately. It's not being called upon in the right way either, because people don't know what it can do. So if there's a problem, so if I give example, we've just been to Scotland where they really implemented it across their healthcare organisation. And what they're getting now is more people coming to them with problems, and then they decide whether it's an educational simulation or a simulation, transformative simulation. And that's, you know, but whereas at the moment, I think we're having it pushed into brackets of what it does. It's only for quality improvement or it's only for education. And we know that simulation is a really creative process. We can do a lot more with it. And I think simulationists need to be given the freedom to using the skills we have to know how to design it and know how to get the best from it. So I think the barriers for me is that external understanding, and that's why internally as simulationists, I feel we need to get that right and be very confident in what we're doing, the methods we're using, the theories behind it, the research, all that kind of stuff, so that we can say to others, we are very competent and knowledgeable in how we use it, and we know it can do more than just what you're assuming it can do. But
Exactly.
what about from your perspective? Where's the...
There's a pile of barriers, but there's also a pile of enablers, you know, so these little mini piles rather than mountains. And I've come across some real barriers even just this week, in that it's people don't like change, so they don't understand our quality assurance and now patient safety teams are shifting, which is why it's really great. And they're starting to use the language that I think we've all probably been using for the last 15, 20 years around human factors and systems, but they're a little bit wary of simulation. So it's about taking people, holding them by the hand and showing them what it can do, but that takes time. And then it takes time to run these things, doesn't it? And it's having the space in the clinical areas to run them, so that, you know, that's a very common one. But it's also trying to find, as we're discovering now, the right tools for debriefing it, because I've chosen after action review at the moment as my predominantly or Pearls, maybe a little bit of Pearls, until I discovered Pearls for safety monitoring and systems as well, which was new to me. But it's trying to find the right debriefing method, and I think that we don't have the evidence to know whether that's right or not. But what with the enablers definitely are, if you've got the right people, they enjoy simulation, they find it's what they do, it's their everyday. If you can create a safe space for them to make those errors or discuss where things are going wrong, then they can create and own the action plan. And that's what's amazing, giving them the power to make the decision. Okay, well, we want to move this piece of kit here. We want to get rid of that bin there, because these are barriers to us having good spatial awareness. Yeah, it's honestly not rocket science. And it's what we should be doing every day, but time stops us doing that.
Yes, and I think that, as you said, most barriers would come from people that at first they're not aware of simulation, or they think it's something that's, you know, this new trendy thing we don't want to be involved with, and it's something that some people do for educational purposes mainly.
Yes.
So maybe reach out to those people, trying to show them that what they've been doing every day could be done like the
Yeah,
same way, a
yeah.
little bit better or improved based on the basics of simulation. And I can see that we can go even beyond the patient safety problems or efficiency in teams problem to also include the cultural differences, how to manage conflicts and relationship problems. And this is something we really do in Morocco, and it's been very popular. Like people, they are demanding of these workshops where we use reality inspired or really like reality based stories to work on and to develop better practices. Professor Muhawi has a question, I guess, or wants to. Yes, go ahead.
Okay, Mariam. So thank you very much for both of you. Your lecture was, as usual, very relevant, brilliant. So I have two questions. The first one for Mary and the second one for Colette. So, okay, Mariam? Okay? Okay, go ahead. So, Mary, I'm a little bit confused about the term of transformative simulation itself, because since that may cause confusion, as it could be interpreted as a different way of conducting simulation. So my question is, could you clarify the differences between convolutional simulation, translational simulation, and transformative simulation?
Yeah. So
And
the transform. Oh, sorry. Go on.
yeah,
Did you say conversion simulation?
sorry,
Did you say conversion simulation?
conventional simulation,
Conventional. Oh, yeah, yeah,
traditional way,
yeah, yeah.
and
Traditional simulation.
translational simulation and transformative simulation.
So transformative simulation, the reason we came up with the transformative term is because that's basically what it's doing. It's transforming what we do in healthcare. So it's not educating people to be within healthcare, it's transforming healthcare through simulation. So it's exactly what it says on the tin, and it does that in all those different ways that we've talked about, inclusion, etc. Now, translational simulation is a method that sits within the SBI framework. So those 7 SBIs that we had, for quality improvement, etc., they've got different frameworks that people use that is a more kind of practical approach. So you might use human factor frameworks, you might use different theories. And the translational simulation one, when we did the research, it sits mainly in, I think it was the improvement and the intervention and possibly the identification for SBIs, but it wasn't doing any of the other the inclusion, involvement, influence. Now, that doesn't mean that that won't happen, but it's more of a framework that they're doing based on their practice. What we're doing with the framework for transformative simulation is bringing all the work people are doing globally and creating that framework of collectiveness. Whereas the translational simulation is based on what some really fantastic people are doing in Australia in their healthcare trust, healthcare institution, that lots of people follow is a really good framework. But our framework is actually lots of different approaches all around the world that we're just trying to elevate and show the different and innovative ways it's being done. So I think what will probably happen as time goes on is, as I said, the 7 SBIs will evolve. And there is an interconnection, which is where it gets a bit deeper between the education and the transformative approach. And you can do both, and people do both. But the reason we're separating them is to give it that legitimacy, the framework, the understanding. And then when people want to do both, it's about how do you bring them together in the design? Why are you trying to achieve both? Is it useful or not? So that it's just about having that clarity in what we're doing in our thinking so that we really become quite clear in what we do as simulationists. Whereas a lot of what we've done in the past, and that doesn't mean it's not been good, but it's very intuitive. But I think we're moving into an advanced state now where it's not so much about the intuition anymore. It's also about how do we properly frame this and understand it. Does that make sense?
Yeah, very good. It makes sense, yes. So, Colette, I have a small question for you. So I will be asking you as the head of the National Society of Morocco. So any advice to be able to deal with this transformative simulation to spread this concept across Morocco and across different medical simulation centers in Morocco? Any advice?
yes, carry on doing what you're doing, because you're already creating a really great network that is your WhatsApp group is, for a start, it's easily accessible. And then I think the other things to do, people need examples, just like Mariam was saying. What is it? What do we need? It is very much trying to create some examples, and Sharon and the Transformative SIG, because I came to the table a little bit late, but they've been trying to get people to submit case studies. And I think people need to see it in 2D, but I think people need to see it in have conversations and webinars like this. I think people need some little video vignettes.
Yeah.
That's what I think. And I think the other thing is, as Sharon was saying, trying to legitimize it. It feels like we're deja vu, coming back to 20 years ago and having to find the evidence to prove simulation was great. I mean, and we all did simulation, just like you're saying, not just for education, but I think it's important. That's where I'm at with my organisation. People are worried. They still see it as an expensive, there's so many people involved, but there's examples of scaling up as well. So one of the really great things that we took away from going and visiting our colleagues in Scotland was something called the Simulation Safety Club. And they ran a simulation and they created psychological safety. But there were over 50 people in that room. Most of them were stakeholders at every level of the situation. And it was on incivility, because people are having conflict. People are quite stressed. It's probably the same in Morocco, although I wouldn't want to make a presumption on that. But people are intolerant of each other, colleagues on colleagues. And the big problem, and they did they had a lovely warm-up exercise, and then they had the simulation team recreate an everyday occurrence, a ward round, where someone's late, someone's been redeployed to a different team. They're all feeling different tensions, and then someone else has come in with quite a heavy sort of cognitive load and pressure. And then we had probably over an hour's discussion, but around what are the problems, yes, but what are the solutions? And that was 50 people, and I thought that was so powerful. So we're going to recreate that back in my trust. And I think as a leader, we can provide these, we can share these ideas, doing what you're doing, was helping people see that we can do, and we're perfectly able. And I think we have to encourage people to share and create these communities of practice.
Yeah, I see.
I don't know if Sharon wants to add anything, but it's creating opportunity.
Yeah, and I
Okay.
think it's exactly as Colette's saying. It's just about us all. For me, the biggest thing we can do as simulationists, experts around the world, is come together, get aligned, and drive it collectively, so that externally everyone sees what we're doing. We know the importance of it, but we've got to get that message out externally. And this is why societies, associations, all these that we're part of are really important. It's our collective community, isn't it? We're stronger together than we are as individuals. And I think in the past, particularly in the UK and other parts of the world, simulation was very siloed. Everyone was reinventing the wheel, doing things on their own. But I think we need to move forward now from that.
Okay, thank you for your feedback. I guess there are some few questions in the chat box, but some of them were already answered by our guests. There is a specific question. I have a question regarding the use of emerging technology in simulations such as AI. Are these tools like AI and virtual reality currently being integrated into healthcare simulation? If yes, how can we use it?
Yeah, so I've put a little bit in the chat there, but I mean, AI is being used in so many different ways now in simulation, and it's like they're almost made for each other in a lot of ways.
Okay.
It's really helpful for designing scenarios. You have to have a look over, obviously, and tweak, but that's, I think, one of the main ways people use it. It's really helpful for debriefing. So it's starting to be used more and more to kind of collate and summarize what was the kind of outcomes of the feedback. And actually, I think going forward with transformative simulation, it'll probably be very useful for, like Colette was saying, to actually capturing data and helping us put it into actions going forward. And we've got a project with ASPI where we're working with different people around the world on a research project looking at how we can use AI and the large language models to kind of make more culturally nuanced avatars, because at the moment the avatars are a bit wooden, they're not very good for these communication skills, and they tend to generally be very American, because that's where most of them are developed. And we're trying to look at how do we take different cultures and see if that nuance in communication is possible through AI. So it's very, yeah, there's lots of ways, but it's very exciting, I think, the simulation.
I'll just tag on to that, Sharon. It reminds me of when everyone was building all those big mannequins, you know, the Meti man. I don't know if anyone's old enough to remember Meti from CAE and Meti before, but they were huge, bulked out mannequins. They don't replicate who we are with body size and skin tone and things. So the AI avatars are also not quite there yet. And so we're on that loop of learning again, aren't we?
Okay, thank you both. I think it's quite time to wrap up. Thank you all for joining us today for this enriching session on transformative simulation for patient safety and beyond. A heartfelt thank you to our distinguished speakers, Sean-Marie Weldon and Colette Laws-Chapman, for sharing their insights and experience with us. And also we want to thank our audience for your thoughtful questions and active engagement. On behalf of Morocco Sim, we look forward to welcoming you to our future webinars. Until then, take care and keep pushing boundaries of innovation in healthcare simulation. Bye, everyone.
Thank you.
Thank you again.
Bye.
Take care, everyone. Thank you.
Thank you. Bye-bye.
Thanks for
Bye-bye.
the invitation.
Bye.
Hope that's